Assalamu alaikum. This week we have this article titled as Survival and Prognostic Factors of Managing Cracked Teeth with Reversible Pulpitis, a 1 to 4 year prospective cohort study. This done by Junghoon Lee and his group from Yonsei University in Seoul in Korea. It was published in 2021 in International Endodontic Journal. In 2008, Rivera and Walton defined a cracked tooth as a tooth having an incomplete fracture with a longitudinal crack line originating from the occlusal surface and progressing in a subgingival direction. Clinical research has shown that cracked teeth with reversible pulpitis can survive without root canal treatment by performing internal splinting with composite restoration or external splinting such as crowns. Also, it has been reported that 79% and 71% pulp survival rate in the cracked teeth with reversible pulpitis restored with full coverage crown, while bidirectional crack splinting was associated with a greater survival rate, which is 93% compared to external splinting alone. This study aimed to investigate the success rate of this bidirectional splinting method and identify the initial factors that could affect pulp survival after splinting by analyzing failed cases. For the methodology, 34 teeth of 33 patients aged from 31 to 80 years, they diagnosed with the cracked teeth with reversible pulpitis and who met the following inclusion criteria were enrolled. One experienced endodontist performed the examination and diagnosis. The inclusion criteria was the presence of a crack line around the surface of the tooth with direct transillumination and visualization. The line should display definite shadow to be considered as a crack line. Also, the presence of pain on biting on a cotton roll in the suspect tooth and the absence of pain on other teeth. And finally, hypersensitivity or sensibility on applying a cold test. For the teeth have lingering pain lasting longer than 10 seconds during the cold test were diagnosed as irreversible pulpitis, while the other teeth with no response considered as having pulp necrosis. All these were excluded. In addition, other categories of longitudinal fractures listed by American Association of Endodontic, for example, craze line, fractured cusp, split tooth, and vertical root fracture, also were excluded. For the treatment protocol of bidirectional tooth splinting, all details is showing in this figure. Procedure has 3 steps based on the persistence or relief of symptoms. After confirmed diagnosis, tooth received immediate external splinting with orthodontic banding, and then the patients were asked to return for re-evaluation after 10 to 14 days. After 2 weeks, internal splinting with composite resin filling after removing the crack line was performed. Additional external splinting on the same day was determined based on the reduction in symptoms. Temporary crown restoration were performed immediately if initial symptoms were relieved on the day of the internal splinting. After 1 month, the symptoms were reassessed and the final external splinting was performed if there was no discomfort. If the symptoms reoccurred, the pulp status was judged as irreversible pulpitis and it was considered as a failure, and root canal treatment was performed if the level of discomfort persisted on the day of the internal splinting, similar to that on the first visit. No additional tooth preparation was performed. So the patient was asked to revisit the clinic a month later for reassessment. If the symptoms had resolved by the next visit, a temporary crown was fabricated. Finally, if the patient experienced recurrence of symptoms, root canal treatment was performed, followed by temporary crown fabrication. If the symptoms resolved after the temporary crown or root canal treatment, the final crown restoration was performed as a final step. If the patient experienced persistent pain on biting a month after root canal treatment, the teeth were judged as survival failure and extraction were recommended. Regarding the follow-up, the patient were asked to return for a check-up at 3, 6 and 12 months and then annually up to 4 years. Regarding the result, the study showed that the recall rate was 97% and the pulp and tooth survival rates were recorded 1 to 4 years after the crown restoration. The pulp survival rate was 91% after final crown cementation and 72% after banding, orthodontic banding. No tooth was extracted, so 100% of tooth survival rate. Pain on percussion was the only statistically significant factor. The Kaplan-Meier curve comparing the pulp survival and cracked teeth with or without pain on percussion at the first visit. In the banding phase, teeth with pain on percussion at the first visit showed a pulp survival rate of 46% in the recall period, while those without pain showed a 94% survival rate. Cracked teeth without pain on percussion at the first visit did not undergo root canal treatment in the recall period. I can conclude that from this study that the bidirectional splinting successfully managed cracked teeth with irreversible pulpitis. Pain on percussion is an important factor in deciding whether to attempt root canal treatment on symptomatic cracked teeth, and the pulp survival rate was 72% after banding, while final crown cementation associated with greater pulp survival rate with 91%, 100% tooth survival rate of cracked teeth managed by directional splinting for 4 years. And thank you.